All right. So I'm equipped with a unique set of skills, one of which is getting a program back on time. So it's my honor to cap off a wonderful day. I am going to sort of give my comments briefly so we have a lot of time for discussion. But you may have found yourself thinking there's been a lot of interesting innovations that have been presented. There's been a lot of really provocative conversation, but how do you actually get these innovations to the bedside? How do you get people to change their behavior? I don't have all the answers for you, but I do have some insights that I hope will help. So I'm going to talk to you about something that's near and dear to my heart, which is implementation science. I don't have any financial conflicts of interest to disclose. I do have a fair bit of grant funding from the agencies on the screen. And as Dr. Tan mentioned, I'm the VP of the APSF, which is a foundation, an organization that is very near and dear to my heart. I have a couple of objectives for you in the time that we have. I want you to be able to say what implementation science is. My bar is pretty low. And I want you to be able to describe the relevance of implementation science to emerging technologies. I'm going to give you first a reflexivity statement. So I do a lot of qualitative research, and one of the things that we do in qualitative research is we tell you who we are, because you want to understand who's talking to you so that you can contextualize what they tell you. So I wear a lot of hats, as many of you do. I'm an anesthesiologist, trying to keep the patients alive. I get to wear zebra lead sometimes, which is fun. I spend most of my clinical time in the ICU taking care of surgical patients, and then the majority of my professional time is as a health services researcher, trying to understand how we deliver care, trying to make sure that we can achieve the outcomes that we set out to achieve. I run a social science lab that uses implementation science to improve patient care. So we're really focused on quality and safety. We do a lot of work around handoffs, but really it's using social science to generate insights about how to care for people and how to get teams to perform the ways that we think they ought to and that we think that they can. I'm the executive director of the Penn Implementation Science Center at the Leonard Davis Institute of Health Economics, which is a mouthful. We also are interested in using implementation science to improve care and outcomes. And there's a big part of my portfolio that's focused on health equity. So that will inflect and inform all of my comments. So I'm a co-lead for Accelerate Health Equity, which is an initiative to improve health outcomes in Philadelphia, where we have the dubious distinction of ranking 67th out of 67 counties in terms of health outcomes. So we've got a lot of room for improvement. And I'm also the co-lead of a newly funded NIH initiative to improve maternal health. And so our hub, Amethyst, is focused on using implementation science to improve maternal health. So I have mentioned this phrase a couple of times, but I want to tell you what implementation science is and what its relevance is to improving outcomes in health. Kevin Costner's character in The Field of Dreams said, if you build it, he will come. And I think in a lot of ways in healthcare, we think if we build the thing, if we make the new, shiny, great thing, they'll use it, right? That's all we have to do is make it. But we know that's not true. So if we think about what gets in the way of our reaching our goals for clinical care and reaching our goals for patient outcomes, some of those issues are related to access and getting the right thing to the right people. Some of those issues are related to knowledge and knowing what the right thing is to do. And I'd say a lot of what we heard today is related to building that knowledge. But sometimes we know what we're supposed to do and we don't do it. And that's where implementation science shines. So really what this field is about is bridging the evidence to practice gap and taking what we know and doing that last mile of delivery of getting it to people, getting it to systems. We have a lot of evidence-based practices in perioperative medicine. This is just a sampling. These are some of the things that we know we ought to be doing, and we don't do them. And so implementation science is one of those tools that we can use to try to understand how to bridge that performance gap. The official definition of implementation science comes from the flagship journal. So Eccles and Mittman said that it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice to improve the quality and effectiveness of health services and care. It's a mouthful. It's a little awkward, but that's the official definition. My favorite definition actually comes from Ann Sales, who's a nurse by background, but is one of the godparents of implementation science. And she said, implementation science is the study of human behavior change under organizational constraints. And that's really what it is. That's distilling it down. So we're studying how to make people change and people that are embedded in organizations. So all of the theories and the concepts that apply to behavior change apply here. And everything we know about organizations, about management, applies here as well. So who should care about implementation? Everyone. But patients and families and caregivers come to us and they assume that they're receiving the best care. They think that we know what we ought to be doing and they expect us to deliver it to them. So they care about implementation a great deal. Researchers who are developing these innovations, other innovators, developers, you're doing the work you're doing because you want it to reach people and you want it to improve health or outcomes. And so you should care about implementation too. The clinicians that are delivering care to the patients, I in the ICU, I want to deliver the best care possible. I don't show up to work to deliver substandard care. Payers and health systems want to make sure that they're receiving value, and we've heard a lot about value today. And then regulators and legislators have an obligation to their populations to make sure that implementation happens. So I'd say it's everybody. My favorite cartoon about implementation says, I've never actually stormed a castle, but I've taken a bunch of siege management courses. It's sort of one thing to think about it and talk about it, and it's another thing to do it. So I want to share with you a few insights about how implementation can work. In the research realm, we think of implementation as late-stage translational research. So it's related to all the other research we do, but it's way on the end. It's T4, it's translating to populations, but it does fit in the whole biomedical research spectrum. A simpler way to think about implementation science is what we call the IMSCI subway that I developed with some colleagues. And basically, if you've been to DC, New York, Paris, pick your metro of interest, you start off here identifying a practice of interest. And so let's say it's post-operative monitoring on the ward. And then you ask yourself, has the practice of interest shown efficacy? Does it work? At a mechanistic level, does it work? If we don't know that, we should figure that out. That's really important. And you want to design for implementation, right? So you want innovations that are implementable, but that's not implementation science. If you have an innovation that you know works, and I think Dr. Khanna presented some provocative data that would suggest that we think this works, then we move on and we ask ourselves, has the practice of interest shown effectiveness? So in the real world, with real patients, with comorbidities, with clinicians that are busy, with competing priorities, does it actually work? If we don't know, we can study that on its own, or we can study that along with implementation. And so everything that's in the lower right corner that's green, and Dr. Tremper, we did red-green, we did color blindness testing on this too. So I know the colors are different. Everything in the lower right corner is implementation science. Trying to understand the context in which these innovations are being implemented, what will make it easier or harder to get people to do it, which strategies work better than others. Admittedly, implementation science is a mutt of a field. So I told you it's human behavior change. I told you it's under organizational constraints. Any theory, any field that has anything to do with those concepts will feed into implementation science. So public health and program evaluation and psychology are sort of standards, along with management science and org theory, but increasingly systems and human factors engineering, and marketing too. There's a lot of marketing concepts that go into implementation. Audience segmentation, how do you deliver the right message to the right people in a compelling way? All of that's relevant to implementation. So what makes implementation science different than what we normally do? Why am I talking to you? Why is it important? There are 5 key features I want to share with you. Just briefly, I teach courses on this, so I can tell you about it ad nauseum, but I'm just briefly going to run through why this is different. We really focus on having a thing. There's an evidence-based practice that needs to be implemented. Now, the sort of bleeding edge of implementation science is applying these approaches to innovations that are still in development. So there are folks that are interested in applying these approaches more broadly. But generally speaking, we have a thing that we have a signal, we have an idea that it works. Otherwise, we're not using implementation science approaches. We do this work in partnership. And the concept of stakeholders has come up a couple of times, and I'm going to bring it up again later too. But this work needs to be done in partnership with the people whose behavior we're trying to change and the people whose outcomes are going to be influenced by the innovations that we're interested in. We don't do this by ourselves. This is not armchair science. And this is one of the key features of implementation that I would offer to you as important as we think about the adoption of emerging technologies, is you have to work with the people who are interested in the thing that you're interested in. Our outcomes are actually different than traditional effectiveness outcomes. So when I do an implementation science study, I'm interested in usability, feasibility, acceptability, appropriateness, adherence. I want to figure out, are people using the thing? How are they using it? Under what circumstances? How do they feel about it? And those are the things that we shoot for. Ultimately, we're trying to improve health, but implementation outcomes are proximal to that. The fourth thing that makes implementation science special is that we love context. Contextual nuance is great for us. All the stuff that makes a trialist insane, all the noise that a randomized controlled trialist doesn't want to see, we like the noise. The noise is information for us. So the nurse that says, oh yeah, we post this thing on the board and then this is how we do this process, but in this unit we do it this way, we love that. And that's the information we need to figure out whether something is going to fly or not. And then finally, we have specific language and methods and theories and frameworks. We have a whole taxonomy of implementation science that makes us a little bit special. There are some focal areas in implementation science that I'm not going to go into, but just so you know kind of what we're thinking about as a field, health equity is very important to us. There's a concept of de-implementation that I think is crucial. So our last speaker, Dr. Shah, alluded to all the quality measures that are coming out of MPOG, and you're creating 10 and then maybe sunsetting one, and at some point maybe that's got to change. We have a lot of things we do in healthcare that we ought not be doing anymore. And so there's a group of folks that are interested in figuring out how to de-implement. Policy dissemination is really important, and then I've highlighted in yellow here the ones that I think are most relevant to what we've talked about. There are some tensions in the field. We tend to do work in individual contexts, but we try to generalize lessons, and we're still trying to learn, if you do a study in 5 different ICUs, what does that mean for all of them? If you do a study in one community, how does that generalize to another? And we're still trying to figure that out. We have lots of imperfect evidence, and I would argue that some of what was presented here falls into that category. The best evidence we can generate is still flawed, and so we have to figure out what to do with that flawed evidence. We have to figure out how to spread and scale. So as we learn lessons, how do we make them bigger? How do we understand complexity? We are interested often in individual innovations, but how do those innovations slot into all of the other things that a clinician might have to do, or all the other issues that a patient has to consider? And how might those other priorities influence the implementation of the innovations that we're interested in? And then we want to balance speed and rigor. So we're doing this because we want to change. We want to foster improvements in health. We want to do that quickly because there are people that need our help now, but we don't want to do it so fast that we don't understand what's happening and why it's happening. There are 3 challenges I'll share with you. One is equity. There are lots of guidelines on how to do implementation work equitably. It's important for us to consider equity because there's a risk of us actually widening evidence to practice gaps instead of narrowing them if we're not thinking about all the different populations that might touch an innovation of interest. So there is this risk. There's also a question of when innovations are ready for implementation and what standards of evidence actually make sense. So I want to complete my time by talking about what implementation science has to teach us about adopting emerging technologies. So I've got 5 lessons for you here. I would say leverage qualitative data. We've talked a lot about big data here. It's often numeric data. Numeric data are great. There's a lot to learn from numeric data, but there's a lot to learn from talking to people and watching them and looking to see what they create. We're running a multi-center study now standardizing OR to ICU handoffs in 5 different health systems, 9 hospitals, 12 ICUs. Every one of them is laid out differently. So if I go into an ICU and I say, oh, all you have to do is put these people in the room and they'll talk to each other and you'll have a thing on the wall. And they're like, which wall? What wall space? We can't all fit in the room. And you don't learn these things unless you actually talk to people and look at their workflows and look at their work environment. So qualitative data can be really helpful in understanding whether implementation is going to fly or not. Workflow is paramount. Looking at Dr. Wenger in the crowd here, there's a lot of other folks that appreciate the importance of workflow. If you tell a nurse, here's one more thing to do, guess what? It's not happening, right? So you want to think about all the things that people have to do, and you want to make their work easier and smarter and not harder. But you want to consider all the systems that they work in. You want to make sure that you understand all of the other tasks that they have to perform. This is an example of a process map that we generated for work that we're doing in handoffs. What you're looking at is a swim lane diagram where every row is a person and every box is a task, and each person has a different workflow. So as we're thinking about changing behavior in all these different settings, we need to understand, well, what is the respiratory therapist doing? What's the nurse doing? What's the anesthetist doing? And it's only with that understanding that we can generate an innovation or an expectation that actually complements the workflow of the people that we're working with. You want to match your implementation strategies to context. And I will say here, relatedly, that education is necessary, but probably not sufficient. And one of the key findings, one of the key insights from implementation science is that you need to understand why people are behaving the way they're behaving. And if you want to change their behavior, you need to target that reason. And sometimes it's a knowledge deficit, in which case education is great, but often it's not. And if the knowledge deficit is not the issue, then educating them is not going to fix it. We have lots of complicated ways of dealing with this in implementation science. This is a logic diagram that takes determinants, contextual determinants on the left. We articulate change objectives, we determine implementation strategies, and then we measure outcomes. This is just to say that there is a systematic way to characterize context and then to come up with strategies that actually match the context. If the problem is that you have a poor culture of safety, the strategy is to target the culture of safety, right? If the issue is that you don't have enough outlets to plug in a new device, you give new outlets. But you need to target the strategies to the context in order for this to work. The fourth is to bring all the stakeholders to the table. I told you I would come back to this. This is something that's really, really important. And it's also important to appreciate that the incentives and priorities of the various stakeholders that you engage will differ. And so you may need to deliver one message to one stakeholder and a different message to a different stakeholder. And it's not being duplicitous. It's targeting the message and the information you have to people in a way that makes sense to them. So we do a lot of stakeholder engaged work. On the left, this is Deborah Grandison, who's one of our patient partners for our Maternal Health Equity Hub. She had a very difficult pregnancy and is really passionate about improving maternal health. And her perspectives on how to do this work are very different than mine, but just as important as we try to engage patients in the innovations that we're interested in. On the right, you see me talking to a couple of our ICU nurses in our handoff work and helping them understand what we're doing and what we're expecting them to do and getting their insights about how workable it is or not. And then finally, you need to design implementable and usable technologies. And this has come up again. You know, if you design something, and I think one of our speakers from Southern California said, you know, where am I going to plug in the thing? I'm in a hybrid OR. It's giant. I already have a lot of devices. Where am I going to plug in the thing that you want me to plug in? And will it work in the trauma bay on the right? Will it work in a low-income country? You have to think about whether the things that you're designing actually make sense for the settings that you have in mind. So hopefully that's something that comes up early in the design process and not something that's late. So these are the 5 key takeaways. I think we're doing okay on time. And I say thank you, and then I think we'll move to the panel.